Hello and welcome to Professor Gadgil's GPAT Academy. Today we will discuss about cell injury. The human body maintains a stable internal environment, a state known as hemostasis or homeostasis, which allows cell to function optimally within a narrow range of physical and chemical conditions such as temperature, pH, and electrolyte concentrations. When the cell encounters physiological stress or pathological stimuli, they may undergo cell injury, which can be reversible if the stress is mild or short lived, or irreversible if the insult is severe or prolonged, leading to cell death. Before injury occurs, cell often attempts to preserve viability through a process called the adaptation, where they alter their structure and function and respond to sustained stress. If the adaptive capacity is exceeded, injury ensures. Feedback, feedback systems are essential homeostatic control mechanisms that regulate the internal conditions. These systems consist of sensor or the receptor that detects a change, a control center like the integrator that compares the input to a set point, and an effector that generates a response. The most common type is the negative feedback system, in which the response counteracts the initial stimulus, restoring the system to its original set point. Examples include the regulation of blood glucose by the insulin and the glucagon, and the control of body temperature. In positive feedback systems, the response amplifies the original stimulus, moving the system rapidly away from the set point to complete a process quickly, as seen in the uterine contractions during the childbirth and the blood clotting cascade. Both types are critical, but negative feedback dominates in daily physiological regulation. Next, we will discuss the causes of cell injury. Cellular injury can arise from a wide variety of etiological agents. The most frequent cause is the hypoxia or the ischemia, a deficiency of oxygen often resulting from reduced blood flow, respiratory failure, or the anemia. Physical agents such as mechanical trauma, thermal extremes, radiation, and electric shock can directly damage the cells. Chemical agents, including the therapeutic drugs like the paracetamol in overdose, environmental toxins, and alcohol, exert their effects by interfering with the cellular metabolism or membrane integrity. Infectious agents like the viruses, bacteria, fungi, and parasites cause injury through the direct invasion or toxin production. Immunological reactions, ranging from the anaphylaxis to autoimmune diseases, trigger inflammation and cell destruction. Genetic defects such as sickle cell disease or inborn errors of metabolism may lead to structural protein abnormalities or enzyme deficiencies. Nutritional imbalances, whether deficiency like the vitamin A or protein calorie malnutrition, or excess like the obesity, disrupt the cellular metabolism. Finally, aging is associated with progressive cellular senses and diminished replicative capacity, making the cell more vulnerable to injury. Next, we will discuss the morphology of cell injury, that is, the adaptive changes. When cells are subjected to persistent sublethal stress, they may undergo adaptive changes that are generally reversible. Atrophy is a reduction in cell size and consequently organ size, resulting from decreased protein synthesis and increased protein degradation via the ubiquitin proteasome pathway. It occurs in conditions of disuse, denervation, and diminished blood supply, such as the shrinking of a limb immobilized in a cast. Hypertrophy is an increase in cell size without an increase in cell number caused by augmented production of cellular structural proteins. It can be physiological, as in the skeletal muscle growth of the bodybuilders or the uterine smooth muscles enlarged during pregnancy, or pathological, as in left ventricular hypertrophy due to chronic hypertension. Hyperplasia is an increase in the number of cells occurring only in the tissues capable of cell division. It is driven by growth factor mediated proliferation and often accompanies hypertrophy. Physiological hyperplasia includes the proliferation of breast epithelium during the lactation and liver regeneration following the partial hepatectomy. Pathological hyperplasia includes benign prostate hyperplasia and endometrial hyperplasia, which can be a precursor to cancer. Metaplasia is a reversible change in which one differentiated cell type is replaced by another better suited to withstand a particular stress. The classic example is the replacement of normal ciliated columnar epithelium of the bronchi by stratified squamous epithelium in chronic smokers. Another important example is Barrett's esophagus, where chronic gastroesophageal reflux induces replacement of esophageal squamous epithelium by the intestinal type columnar cells containing the goblet cells. Although metaplasia is initially protective, persistence of the stressful stimulus can lead to dysplasia and ultimately malignant transformation. Dysplasia is not a true adaptation but a pre-neoplastic change characterized by disordered cellular growth, loss of uniformity of individual cells, and disturbed tissue architecture. It is most commonly described in the uterine cervix as cervical intraepithelial neoplasia. Dysplasia may be reversible if the inciting cause is eliminated, otherwise, it can progress to carcinoma in situ and invasive cancer. Next, we will discuss the pathogenesis of cell injury. The biochemical mechanisms of cell injury converge on a few critical intracellular systems. A central event in the most forms of injury is a decline in cellular adenosine triphosphate levels, which leads to failure of energy-dependent ion pumps, particularly the plasma membrane sodium-potassium ATPase. This failure causes sodium and water to accumulate within the cell, resulting in cellular swelling, the earliest and most common morphological manifestation of reversible injury. Damage to the cell membrane further disrupts the ionic and osmotic homeostasis. Loss of membrane integrity allows an influx of calcium ions into the cytosol, which activates a host of potentially lethal enzymes. The phospholipases degrade membrane phospholipids, proteases cleave cytoskeletal proteins, and ATPase consume the remaining ATP, and endonucleases fragment the DNA. These calcium-mediated events are a hallmark of irreversible injury. Leakage of intracellular enzymes such as alanine aminotransferase, aspartate aminotransferase, lactate dehydrogenase, and creatinine kinase MB or the CKMB through damaged membranes serves as clinical biomarkers of tissue damage. Mitochondrial damage represents the point of no return in cell injury. Opening of the mitochondrial permeability transition pore collapses the proton gradient across the inner mitochondrial membrane, halting the oxidative phosphorylation and causing severe ATP depletion. Simultaneously, cytochrome C is released into the cytoplasm, triggering the intrinsic pathway of the apoptosis. Ribosomal damage, specifically detachment of ribosomes from the rough endoplasmic reticulum, leads to reduced protein synthesis. In hepatocytes, this failure to produce apolipoproteins results in the lipid accumulation, manifesting as fatty change or the stenosis. Nuclear damage appears later and is characterized by a series of changes. First is the pycnosis, in which there is nuclear shrinkage and chromatin condensation. Second is the karyorrhexis, in which there is fragmentation of the nucleus. And last is the karyolysis, in which there is dissolution of the nucleus due to endonuclease digestion. These nuclear alterations are definitive markers of cell death. Next, we will discuss the enzyme leakage and the cell death. When cell membranes are severely damaged, intracellular enzymes leak into the bloodstream, providing crucial diagnostic clues. Elevated ALT and AST indicate the hepatocellular injury. CKMB and troponins are markers of myocardial infarction. LDH is a non-specific indicator of the cellular damage, and amylase and lipase rise in the acute pancreatitis. Cell death occurs by two principal mechanisms. Necrosis is an unregulated, accidental form of cell death that always triggers an inflammatory response. Its morphological types include the coagulative necrosis, the most common form seen in the infrax of solid organs except the brain. Liquefactive necrosis, typical of brain infraction and abscesses, and caseous necrosis, characteristic of tuberculosis with a friable, cheese-like appearance. Fat necrosis, caused by lipase action on adipose tissue in acute pancreatitis, and fibrinoid necrosis, seen in immune-mediated vascular injury. Apoptosis, in contrast, is a programmed energy-dependent process of cell suicide that does not provoke inflammation. It is triggered either by intrinsic signals such as the DNA damage and the mitochondrial cytochrome C release, or by extrinsic signals through death receptors like the FAS. The execution of apoptosis is carried out by a family of proteases called the caspases. Next, we will discuss the cell swelling intracellular accumulation, and the calcification. Cell swelling or hydropic change is the earliest and most readily reversible morphological alteration in the cell injury. It results from the ATP depletion and failure of the sodium potassium pump, leading to an influx of sodium and water. Affected organs appear pale, swollen, and heavier than normal, and under the microscope, cells show small clear vacuoles representing the distended endoplasmic reticulum. Intracellular accumulations occur when cells are unable to metabolize or transport substances, leading to their buildup. Fatty change or the stenosis is the accumulation of triglycerides, predominantly in the liver due to alcohol abuse, diabetes mellitus, or obesity. The liver becomes enlarged, yellow, and greasy. Protein accumulations are seen in the renal tubular cells in conditions of heavy proteinuria, while glycogen accumulates in the diabetes mellitus and glycogen storage diseases. Pigment accumulations include the carbon particles in the lungs, lipofuscin as an age-related wear and tear pigment, and the hemosiderin in the iron overload states such as hemochromatosis or repeated blood transfusions. Pathological calcification is of two types. First is the dystrophic calcification, which occurs in the dead or degenerating tissues despite normal serum calcium levels. It is seen in atherosclerotic plaques, old tuberculous granulomas, and the damaged heart valves. Second is the metastatic calcification, which results from the hypercalcemia and affects otherwise normal tissues, preferentially those that lose acid, such as the kidneys, gastric mucosa, lungs, and systemic arteries. Hypercalcemia may be caused by hyperparathyroidism, vitamin D intoxication, or extensive bone destruction. Next, we will discuss the acidosis and the alkalosis. Acid-base balance is critical for normal cellular function, with normal arterial blood pH ranging from 7.35 to 7.45. Metabolic acidosis is characterized by a primary decrease in the bicarbonate and pH, commonly due to diabetic ketoacidosis, lactic acidosis, diarrhea, or renal failure. The compensatory response in the hyperventilation to lower the partial pressure of carbon dioxide. Metabolic alkalosis with elevated bicarbonate and pH results from vomiting, diuretic therapy, or excessive antacid intake and is compensated by the hypoventilation. Respiratory acidosis arises from the carbon dioxide retention due to conditions like chronic obstructive pulmonary disease or the respiratory depression, leading to a low pH. The kidneys compensate by increasing the bicarbonate reabsorption. Respiratory alkalosis is caused by hyperventilation, like the anxiety, high altitude, early salicylate poisoning, resulting in low carbon dioxide and high pH, with renal compensation decreasing bicarbonate reabsorption. The anion gap, calculated as sodium minus the sum of chloride and bicarbonate, is useful in identifying the cause of metabolic acidosis. An elevated anion gap suggests accumulation of unmeasured anions. Remembered by the mnemonic mud piles, that is methanol, uremia, diabetic ketoacidosis, paraldehyde or propylene glycol, isoniazide, lactic acidosis, ethylene glycol, and salicylates. Last is the electrolyte imbalance. Electrolyte disturbances have profound effects on the cell function, particularly in the excitable tissues. Sodium, with a normal serum range of 135 to 145 milliequivalent per liter, is vital for osmotic equilibrium and nerve impulse transmission. Hypernatremia causes cellular dehydration and CNS dysfunction, while hyponatremia leads to cerebral edema, confusion, and seizures. Potassium is crucial for maintaining the resting membrane potential. Hyperkalemia produces progressive electrocardiographic changes, including the peak T waves, loss of P waves, widened QRS, and ultimately the cardiac arrest. Emergency management often includes intravenous calcium gluconate to stabilize the myocardium. Hypokalemia manifests as flatted T waves, prominent U waves, muscle weakness, and increased risk of arrhythmias, especially when combined with digitalis therapy, as digoxin competes with the potassium on the sodium potassium pump. Calcium is essential for muscle contraction, bone structure, and blood clotting. Hypercalcemia presents with symptoms often summarized as stones, bones, groans, and psychiatric overtones, along with a shortened QT interval. Hypocalcemia causes neuromuscular irritability, leading to tetany, with clinical signs such as Vostex sign, that is facial muscle contraction on tapping the facial nerve, and Trousseau's sign, that is carpal spasm on inflation of a blood pressure cuff, and a prolonged QT interval on the ECG. Magnesium serves as an enzyme cofactor and influences neuromuscular transmission. Hypermagnesemia results in muscle weakness, hypotension, and respiratory depression, while the hypomagnesemia manifests as tremors, seizures, and cardiac arrhythmias, often accompanied by the hypokalemia. Maintaining the delicate balance of these electrolytes is essential for cellular homeostasis and overall organ function. That's all for today. If you like the video, please click on like button, follow, share, and subscribe. Thank you.